Hi there, I'm Dr. Danielle Kelvis here to talk to you a little bit about personalized medicine. Currently, general medicine is just kind of that, right? General. Healthcare providers operate through a systematic algorithm for treating chronic illness. Older physicians reminisce the old days where they could practice the art of medicine. But in this new era of insurance and billing and drug advertisements, the art has been a bit abandoned for a more rigid sequential treating process. So, to improve this, a new era of personalized medicine is born. So, researchers are currently developing a system that capitalizes on performing genetic analysis on patients to better gear treatment to their blueprint DNA. So, personalized medicine is projected to improve medical decision making, optimize disease prevention strategies, reduce the use of inferior medications, and decrease medication toxicity and exposure, all with the hopes of improving patient satisfaction, health outcomes, uh, adherence to therapy, while reducing healthcare costs. Uh, Extensive research is still required before routine genetic testing is recommended on a wide scale. And clinicians must be trained in how to critically apply genetic information with risk prevention, as much of the data collected does not yet directly imply how a patient will respond to a treatment or medication. So, most of the current data has been studied and obtained in primarily European countries. Patients of diverse origins and backgrounds have yet to be included in some of the wide scale studies to identify genomic trends. So many remain skeptical due to the lack of predictive biomarkers, the irreproducibility between patient genes and response, and the high cost of genetic testing. The cost is projected to decrease substantially with the advent of direct pharma and lab testing to consumer advertising, and ease of ordering lab tests in a way that circumvent healthcare providers. Currently, we can sequence DNA with relative ease by use of a saliva or blood sample. Eventually, the idea is for healthcare providers to receive the lab results and know specifically, which medications to use or not use, and what diseases the patient is at high or low risk of developing. It can tell us if the patient will quickly metabolize a medication, meaning will they require higher doses, or if they're a slow metabolizer, so requiring a smaller dose. Extensive studies are required to measure and assess the accuracy of making medical decisions based on genetic data in these specific scenarios for each and every medication and disease pathology. Long-term studies are required to assess positive or negative predictive value and determine if these changes in treatment make any improvement, overall and on morbidity and mortality, which is the ultimate goal, right, of personalized medicine. So for this to become standard of care, the large body of healthcare providers will need to undergo extensive genetics training to learn how to interpret this data. For example, in the setting of hypercholesterolemia diseases, several genetic mutations have been identified. Patients are not routinely screened and treated for elevated cholesterol and triglyceride levels until after about 40 years old. So, a lifetime of high cholesterol increases a patient's risk of developing coronary artery disease, subsequent heart disease, or myocardial infarct, better known as a heart attack. If the family knows they carry a particular gene, then screening and treatment would begin at a much earlier age, right? Potentially increasing the longevity of their life. What remains to be studied, however, is if these younger patients, when compared to those who, do not receive personalized medicine, do they actually live longer, or do they sustain any side effects to starting statin medications sooner? We may lower their cholesterol, but are there adverse risks to starting meds in their 20s instead of their 40s? Will we see a reduced rate of coronary artery disease and MIs? Will disclosing this information to the patient actually result in lifestyle changes, better patient adherence, and improved outcomes? When the information is presented to the healthcare provider, will they act to aggressively treat the patient? Or will they defer to the current treatment guidelines, right? Waiting to start the patient on medication until he or she is 40 years old. So many medications, such as statins, may not have been studied in younger populations or, be FDA approved for that age. Uh, so personalized medicine is unquestionably the future. The more patients that undergo genetic testing, the more data researchers will have to answer the above questions.